So this is a quick video on anterior cruciate ligament or ACL injury. I think everybody out there is familiar with the ACL that you hear about in sports all the time. People have a family member or friend that has had a blown knee or some sort of disruption, and a large percentage of the time that's from the anterior cruciate ligament. The anterior cruciate ligament runs in the middle of the knee. It attaches to the more front part of the tibia, or the anterior part of the tibia, and attaches back on the femoral condyle back in this area. And the reason we call it the ACL is because it's anterior on the tibia here. It controls the tibia moving forward on the knee. So this is the motion that typically occurs when people tear their ACL, is the tibia goes too far forward relative to the femur, and that creates part of the injury. The ACL is very common in sports, soccer, basketball. We see it in football. Clearly, living in Utah, we see a lot from skiing, and it typically is a twist where a patient will feel a pop, have some immediate pain, have pretty quickly after that some swelling, and not feel that they can continue their activity. Many patients feel there has to be some sort of collision to create an ACL tear, but in fact, most of the ACL tears we see are non-contact, and many of you have maybe seen that, say with basketball, someone going in for a layup, coming down in a funny position, and then grabbing their knee all of a sudden. Unfortunately, females, given the same activity compared with males, say soccer to soccer or basketball to basketball, are at a higher risk of ACL injury than their male counterparts. With a suspected ACL tear, in addition to the history that the patient gives us and the exam and seeing the tibia move relative to the femur like I showed, we commonly get an MRI to evaluate the ACL. Also, we evaluate the meniscus and the cartilage to see if there's anything else that's been damaged at the time of the ACL injury. Clearly, although we commonly operate on ACL injuries, not every ACL tear has to have an operation. There are people with lower demands, do more straight ahead activities, perhaps are older or have other commitments in their life. And so certainly we do consider non-operative care for some of those patients. The reality is that a lot of the patients that we see are younger, highly active, highly motivated, that live here in Utah, get in the mountains and are active and want to go ahead and return to those activities, which means many times we do need to consider ACL surgery. After an ACL injury, we want the knee to be returned to normal as soon as possible. So what we emphasize is for the patient to regain that full extension or ability to straighten the knee, and in addition, get their bend back. We use other means in physical therapy, and patients can do things at home like ices and wraps to try to decrease swelling. We want patients to start to walk, maybe get on an exercise bike to start to be a little bit active, maybe not playing sports, but we want to get that knee calmed down before we consider any other invasive treatment. ACL surgery is done arthroscopically, where we take the microscope, go inside the knee. We obviously evaluate for other injuries and meniscus or knee cartilage tears and deal with those at the same time. There's a discussion with the patient concerning grafts that we use for ACL surgery, and that's a very in-depth discussion that is kind of beyond the scope of this video. But we do use a tendon material to replace in the ACL. So fundamentally, we are replacing this ACL with another tendon and attaching it down to the tibia and then through a tunnel and up into the femur in the same fashion that somebody had their prior ACL in the knee. Once we do that, we want to get quick therapy going afterwards, get people weight bearing, get them moving, treat them like right after their injury. We do have to modify that at times based on meniscus surgeries or cartilage surgeries that are done, which might make us go slower or have to do more non-weight bearing. Physical therapy is very important during this period. We'd like to get people off crutches in the first 10, 14 days, get them reasonably independent on their function. We get them in physical therapy so that they can get help to, again, as quickly as possible, regain that function in the knee. It is important to know some statistics after an ACL tear. Unfortunately, no matter how it's managed, no matter how it's fixed, the potential of re-injury in that individual is higher than in the regular population. There is also a not insignificant chance that they could injure the graft after surgery. Conversely, there's not a small chance that they would potentially be able to injure their other knee. Age plays a big role in this. So patients under 20 years of age have a much higher re-injury to the graft or injury to the other knee than people who are a little bit older. But patients need to know that this ACL surgery does not make them bomb-proof, so that on return to activity, nothing bad can happen because repeat injury can occur. So this is a quick video to give you some ideas about ACL injury and management. We can't give you exhaustive coverage of all the grafts, all the associated surgeries, risk complications, and things like that, and that'll need to be discussed with your surgeon to find out what's really best for you.